Welcome to week 11. We will be talking about the second part of our examination of medical terminology, as well as medical philosophy and its application. Let's begin with our first slide in this slideshow.
And let's continue our conversation, the conversation we began in the first part of the semester about basic utilized every day in healthcare. Let's go and examine some basic terminology and structure. Now, a lot of these things should be already familiar to you because we talked about word root, prefix, suffix, and combining form. So this will be the practical application of the theory we previously encountered. So again, in these examples, with meanings, word root, cardiogram, recording, the record of the heart, right? Where cardi comes from the Proto-Indo-European heart term, if you remember. You can find in English, you can find in German, you can find in Italian, and so on and so forth, right? Prefix, what comes before, right? Peri, P-E-R-I, cardium, pericardium, around the card. Think of periphery, for instance, okay? Suffix, carditis, carditis, inflammation of the heart. And finally, combining form, cardiomyopathy, cardiomyopathy, okay, heart muscle disease. Now, you might see here that there are vowels that connect the terms, that connect prefix, root, and suffix, okay? And those vowels are in themselves containing several phonetic rules, but for now, I would like to focus only on the basics. Some suggestions, okay? If the suffix begins with a vowel, do not use a combining vowel. As an example, arthritis, not arthroides, okay? So there's no need to add that O there, right? If the suffix begins with a consonant, use a combining vowel. For instance, arthroscope, not arthroscope, arthroscope, okay? Which contains the in-between sound O. Now, some of those sounds will be fully vocal sounds. Some might be semi-vocal sounds. But for now, this is just an example how to combine these words. And we will leave the etymological and historical reason aside for now. Combination part 2. All right. Life, we talked about that. Bio, okay? Or bi, okay? Life. Vios, okay? Vios, vis. Remember that bios in Latin, okay? Carcino, cancer, okay? This is easier to understand because the root is the same in both English and the Greek Roman equivalent. Cardio, we already discussed that. Chemo, chemical, okay? Chemotherapy, for instance. Cis, cheese, kiss, to cut, right? Dermatos, skin, derma, epidermis, right? Dermatology, for instance. Entero, small intestine. Gastro, stomach related. Gynekos, gyneco, depending on which pronunciation you focus on. Female, the term, of course, is connected to gynos, as well as the other Indo-European connected language. Jena, for instance, we mentioned this before. Gene, gender, genitalia, all those are connected to this creative power, right? To this creativity component, to the female component as well, okay? So female gynecos. Hemat, blood, okay? Hematology, for instance. Immunity, immune system. Laryngo, voice box, okay? Laryngitis, for instance. Nephro, kidney. Neuro, nevro. Now think of nerve and always think about how the etymology of Indo-European words at times create a substitute between vowel sounds and consonant sound, or rather than substitution, a different order between two letters. In this case, we're talking, of course, about vocal or semi-vocal sound that turns into a consonant and a different order. So nevro, nervo, okay? So for instance, nevra, nevro, neuro, neuro, related to the nerve, okay? Ophthalmo, eye related, okay? Otolaryngology, ear. Path. Now, this is an example that we utilized previously when we talked about naturopathy. Okay. Now, of course, path has also an English or modern English etymology, right? Path as in, of course, path, but also path as related to the pathos, to the passio, okay? Pathology, right? Pulmono, lung related, okay? Pulmonary, pulmoni. And finally, rhino, related to the nose. Some prefix here, some prefix. An, anti, auto, brady, d, dis, endo, epi, u, x, and extra. In the Greek Roman pronunciation, a means without or away from. An and without. Anti, against. Auto, self. Brade, slow. De, without. Dis, painful, difficult, abnormal. Dysphoria, for instance, okay? Endo, within, inner, okay? Now think of this, for instance, as into, endo, in, right? Within, inner. Epi, right? Epi. Epi, upon, over. Eu, normal, good. Euphoria, for instance. Europe, okay? Europa has the same etymology. Ex, pronunciation very similar both between English and Greco-Roman. Ex, external, outward, okay? In some cases also away from, okay? And extra, outside of or on top of, okay? In some cases. Hetero, different. Homo, same, okay? Think of the term here, okay? Homo, same, okay? Same. Hyper, over, above. Hypo, hyper. Under, below. Inward, or not, as opposed to, okay? And that really requires a further knowledge of the roots that follows the prefix in this context, okay? Inability, for instance, okay? Not ability, right? Inter, among, in between, okay? International, for instance, right? Intra, within, inside. As example, outside of medical terms, internet as opposed to intranet. Macro, large. Micro, micro, small. Neo, new. Para, beside, near, abnormal. Two, like parts of a pair, similar etymological connection, right? Per, through. Three, peri, around. Post, after. Pre, before or in front of. Pro, before. Pseudo, false. Re, retro, back or behind. Sub, below, under. Tachi, trans, through, across. Ultra, beyond. Excess, not, in the pronunciation of the Greek-Roman tradition. Number 4, numbers. Most of these are quite common and common knowledge. So this will be, again, just repetition. And of course, I did not count, to 100 here, just few examples that the most commonly utilized, at least from the perspective of medical terminology. Uno or mono, one. B or D, two. Dia, bi, right? Three, tria, three. Quadri or tetra, so the first one Latin base, the second one Greek base. 4, hemi or semi, semi, half. Nulli, none. Nihil will also be none. Pan, pan, all. Okay. Think of panic, for instance, related to the god Pan, right? Multi, poly, or poly with a epsilon. Many. Okay. Again, multi, multi from the Latin, and poly from the Greek. Okay. The general advice is that if you can certainly use an English pronunciation, but in doubt, I tend to advise to utilize the closest possible to the original correct pronunciation. For instance, should we say multiverse or multiverse? My advice would be to stick to the original. The original will be multiversum, multiversi, right? So multiverse will be preferable than multiverse. But again, the purpose of studying mega terminology is to make ourselves understood. So I also want to emphasize the importance of being flexible in the way we pronounce words. Suffix combination part 1, attached adds meanings such as condition, algia, algia, pain. Neuralgia, for instance, okay? Nostalgia used to be also a disease, itis, inflammation. Procedure, ectomy, surgical removal, mastectomy. Again, few more examples, some repetition. Algia, algia, pain. Cele, cele, hernia, protrusion. Site, cute, chite, cell. Dynia, pain. Dilatation. Gen, that which produces. Remember what we said earlier about the compound, gunos, generation, genitalia. Genic, produced by. Aya, state, condition. Iasis, abnormal condition. Ism, state of. Itis, inflammation. Logist, from logos, neurologist, psychologist, the one who studies. Logic, again, from logos, the study of. Endocrinology. Lytic, destruction. Malacha, abnormal suffering. Megaly, enlargement, large, from mega. Oma, tumor, mass. View, right, from optical, if you remember that, okay. Osis, abnormal condition. Pathy, disease. Few more. Plasm, formation, development to plasmare, right? Plegia, paralysis. Ptosis, drooping. Rage, hemorrhage, for excessive abnormal flow. Regia, abnormal flow condition, okay? Regia, rea, discharge, flow. Rexis, rupture, rexis. Sclerosis, hardening. Stenosis, narrowing. Therapy, therapia, I didn't actually use the Greek Roman spelling here. Treatment, and trophy, nourishment, development. Let's continue. Some surgical terms, suffixes. Centesis, puncture to withdraw fluid. Surgical removal, ectomy. Ostomy, surgically create an opening, ostomy. Otomy, cutting into, otomy. Pixie, surgical fixation. Plastic, surgical repair. Roughy, suture. Instrument to cut. Gram, record or picture. Recording. Meter, meta, instrument for measuring. Metry, measuring. Scope, from scoping. Instrument for viewing. Scopic, visually examining. Scoping, remember, and scoping. Work on constructing some of these words, and those are, of course, just basic examples. And I also want to mention that especially in English, the pronunciation might change a little bit once you create a combined word, right? Because contrary to Greek and Latin, which are very phonetically based, transparent, we could say, language, the opacity of English creates a shift in pronunciation. And that's why sometimes it's more difficult to render that pronunciation since it does not follow the combination of itself. Okay, so let's be flexible about that. And of course, the best way to learn how to pronounce words is actually in practice, in the connection between the word itself and the context. For example, hypo, again, below or under, dermal, meaning the skin, ic, I see, meaning pertaining to, combined to form the term hypodermic, meaning pertaining to under the skin, okay? Hypodermia. Example here, define each word part, gastro, so O is for combination, right? Combining vowel. So combination with no meaning, gastro, enter, small intestine with another O, and finally, logy, which is study of. Combine the meanings of the two parts, study of the stomach and small intestine, gastroenterology. All right. Now, this is also something that has to do with grammar. And of course, there is a bit of a debate whether English should follow the Latin or Greek grammar structure in everything, in all the vowels, or whether there should be a little bit of a relaxed attitude about the way we interpret singular and plural. And of course, there might be terms that might come from different traditions, right? We talked about mathematics, we talked about algorithm, for instance, which term does not come from an Indo-European language, but from a Semitic one, from Arab. And so there are certain languages that do not only have a singular and plural form, they also have a dual form, right? But all things considered, those are just some elements that are commonly utilized and considered as valid and current in English when we talk about medical terminology. So word ends in a or a, okay? Vertebra, vertebra, the plural is vertebrae, okay? Now, of course, there are some difficulties because sometimes the plural spelling is no longer in modern English matched by the plural phonetic corresponding presentation. So the pronunciation is different. For instance, if you think about alga, A-L-G-A, okay, with the meaning of alga, of course, the plural is supposed to be just as vertebrae, algae, and unfortunately is mispronounced very commonly so as algae, okay? Now, this does not make sense phonetically speaking, so I would encourage you to master the original pronunciation, and then if you want to give a twist to it, then feel free to do so depending on the context. Also, whether you are in New England, for instance, or somewhere else, right? So anyway, vertebra, vertebrae, okay? Thorax, thorax, thoraces, 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 okay? Appendix, appendix, appendices, okay? Metastasis, metastasis, okay? Metastasis could be a possible pronunciation. Sarcoma, sarcomata, okay? Same as scheme, right? Schema, schemas, schemata. Phalanx, phalanx, phalanges, phalanges. Ganglion, ganglia. Of course, ganglion, ganglia will be a possible pronunciation. Nucleus, nucleus. Nuclei. You could pronounce it nuclei. Nuclei is really a bit of a stretch, okay? But of course, if the purpose is to make ourselves understood, I guess you could use nuclei as well. Ovum, ovum, ova. Ova, it could be okay as long as you don't mispronounce it as ove, right? Biopsy, biopsy, biopsis, biopsies. Okay, so I would at least encourage you to memorize the plural, which in the end it's pretty straightforward. It doesn't present a lot of irregular forms here. Okay, And of course, there might be, etymologically speaking, some differences between, the 7th of Latin and the archaic Greco-Roman form. But for the most part, they're pretty easy to memorize. All right, just few more things. Let's talk about part 2, medical philosophy and application, and we are really switching gears. I mentioned a few weeks ago that medical philosophy plays a fundamental role in healthcare. It informs the way we understand our treatment. It informs our diagnostic methods, our practice skill set, our ability to interact with our patients. So I really like to take a step back and begin from the basics here. So let's begin with the first slide here. The first slide is simply a quote from the book. Numbers don't lie, nor they tell the truth. Okay? I want to mention this because very often in healthcare, we have a tendency, which is to some extent justified, to rely on facts as if facts are, so to speak, separated in an objectivized form from the interpretation, in a sense that, well, facts don't care about your emotions, so to speak, and so numbers do not lie, nor they tell the truth, because they are separate, okay? Which means two things. The first is that the more science fact basis our practice is, the better it is from the perspective of accuracy and precision, as well as in order to avoid bias. But at the same time, they don't tell the full story, okay? They're not interpretation. And that's why we also have to develop some skills that are focused on this clinical interpretation, which is only possible if you have a sound grasp of theoretical models in medicine, okay? So this is just a little premise here, a little quote. Introduction. This is an introduction that it's also a quote from Aulus Cornelius Celsus, Aulus Cornelius Celsus. Beginning, medical science thought of itself as part of philosophy because both the treatment, cure, diseases, and the analysis, contemplation of natural things are known due to the work of the same authors, especially given that the ones who resorted to medicine were the ones who weakened their body in the quietness of meditation and in the night vigils. Thus, we know that we can find many learned philosophers in this science, among them the celebrated Pythagoras, Empedocles, and Democritus. Hippocrates, whom some believe to be Democritus' disciple, was in fact the first one among all those we should mention to separate this discipline, which is medicine, from philosophy. All right, so aside from the, in my mind, interesting historical background of this quote, you might wonder why include medicine in philosophy. We talked about that briefly when we analyzed ranks, degrees, certifications, and levels of healthcare professions. And we mentioned that a PhD is the highest achievable title, right? With exception of the DSc, the Doctor of Sciences. So a PhD is an acronym, Doctor of Philosophy. Now, why would someone be awarded a PhD, a Doctor of Philosophy, in a field completely different in philosophy? A PhD in medicine, a PhD in biology, a PhD in neuroscience, etc., etc. Well, the reason is because philosophy is the big umbrella term, not because it's an imprecise term, one size fits all term, but because philosophy, as the name implies, love of knowledge, as well as knowledge of love, knowledge of a deeper understanding what it means to be human, is also the primary structure in which everything else finds its place, right? Now, of course, medicine is also an applied science, but without interpretation that has to come from my deeper understanding of theory, then medicine fails to do its job, okay? Now, you might also wonder why analysis is contemplation and treatment is cure. Well, treatment and cure, it's easier to understand. And of course, we should separate disease, disorder, and illness. Okay, we talked about that previously. But contemplation is also a synonym in this context of this combination between a rational, analytical self-analysis, as well as this detached and yet very profound ability to understand something that's not just visible in the empirical sense, but has to be perceived. So this is just a brief introduction as to why medicine and philosophy are connected and why philosophy is a fundamental notion and skill set that we should master in order to practice medicine appropriately. Next slide, basic premises and theoretical assumptions, part 1. Another quote from the book. In other words, the efficacy of therapeutic interventions also depends on the patient's system of beliefs. What is very interesting is the fact that this effect often seems to happen regardless, that means without the direct connection, important factors such as level of education and personal awareness, knowledge of the ongoing process, as during the very administration of the placebo. For instance, a positive response can appear even when just a sugar pill has been prescribed to a medical professional, in this case in the role of a patient, as part of a research on positive therapeutic outcomes. Now, again, philosophy as love of knowledge, love for knowledge, as well as knowledge of love, okay? This is connected to what we said a few weeks ago regarding the level of spirituality, religiosity, or lack thereof, and in general, the worldview that each patient has, okay? So our treatment, beside solidly based scientific data, should also take into account these elements of the patient presentation, the complexity, holistic presentation. In this specific example, the patient's system of beliefs. And again, I encourage you to search for the peer-reviewed meta-analysis providing evidence for this. It is important to pay more attention to the role in terms of therapeutic success of all of those dimensions linking therapy, interaction therapist-patient, interaction environment therapist-patient, both in the sense of internal and external environment, and those areas which touch upon those very spiritual and religious dimensions which cannot be simply reduced to psychological activity or mental health disorders. Now, of course, this approach is by definition critical of reductionist, materialist perspective, right? In a sense, they do value the existence of transcendental elements that do not fit evidence-based science, as in whatever is observable is all there is, okay? But it's important to understand that we play a role as healthcare providers, okay? So when we advise nurses, for instance, to be kind, informed, empathetic to our patient, we don't simply mean, again, to simply present a professionally proper way to interact with the patient so as to prevent, I don't know, the patient from suing the hospital, for instance, because this is an essential portion of what we do. In other words, in trying to understand the role of wishful thinking, hope, and placebo as they connect with religion and medicine, we might have to shift our attention from the question, why does this not work in all these cases, to what does it work in this case? What do we mean by that? Well, we mean the following thing. In medicine, we have to be well informed from the medical standpoint about the most efficient and effective way to treat a specific disease, for instance, in the vast majority of cases, right? We have to have a solid knowledge of epidemiology, biostatistics to understand what are the parameters that will allow us to claim that this remedy will work under the same circumstances for that specific issue for the vast majority of cases, okay? Now, and those cases that do not fit in the picture should be considered from this perspective as outliers that might need a further explanation as to why the medication did not work. Maybe due to medications, chemical interaction, due to previous allergies or intolerances or other medical comorbidities, right? So this is the first question. Why does this not work in all these cases? For instance, working on this philosophical assumption, using this approach, why doesn't we have to move that into why does it work in this case? Namely that for the vast majority of the population that we treat, it is absolutely important to base our clinical judgment on solid scientific evidence, and by that again we mean biostatistics and epidemiology. But then we want to make sure that we see the individual underneath the label of patient. So why does this approach work in this case? What is this presentation telling me? Okay? What else may I have missed in my interaction with the patient? Is it something I said? Is it something that was mentioned in a way that did not fit my categorical analysis that could provide further information that could potentially improve my treatment? Okay. And in this context, we talk about wishful thinking, hope, and placebo. That's a section of the book that talks about those aspects, in a sense that placebo and nocebo are constantly already discussed as this lack of scientifically demonstrated, proved validity of the interaction, something that goes outside of what is considered a causal effect. Okay, hope and wishful thinking are connected terms, but they also mean what role the patient plays as in his or her own well-being, with our support to bring this to their attention, to bring it to the surface. Okay, empowering a patient means just that, to make sure that we understand where they come from, so we can give them not necessarily medical recommendation, because those medical recommendations after all are indeed based on solid science, but we might speak their jargon in order to achieve that insight from within. So in other words, the patient is the expert in his or her own well-being. We're simply shedding light on those areas that need to be worked on. Okay. All right. Some important distinctions, since we talked about healthcare in general, between philosophy of medicine and medical philosophy. They're both extremely important in healthcare, but they focus on different sides of the spectrum. Okay, so philosophy of medicine as a part of philosophy of science, so therefore connected to epistemology, focus on knowing that, so knowing facts, structures, combinations, things such as axiology, things such as orders and lists and processes and mechanism and taxonomies, etc., etc. Medical philosophy is also based on those assumptions, but it's about knowing how. It's also a method. Okay, it's not something that is separated from the intervention. It's something that informs our way to deal with the situation, to treat the patient. I want to stress, because it's extremely important, we study philosophy in healthcare not to have a, how can I say it, a constructivist or deconstructivist or postmodernist approach to science and simply challenge all the claims that the science has. We certainly take a critical stance against scientific, extreme positivistic perspective in science, themselves connected to reductionist, materialistic elements. Then, of course, students are completely free to reject. This is just the approach that I personally take in teaching this field. But we also go beyond that. We focus on a method that increases our clinical skills so that our treatment is better. Wonderful. Some question addressed by medical philosophy, and this will be the last part of this analysis. And of course, the field of medical philosophy is extremely fascinating. It's very, very complex, very profound. But for a course in an introduction to healthcare and medicine, those are common use basic questions that can inform our practice. And then if some of you have an interest in discussing this thing further, I'll be happy to address those questions. All right, how can we understand the specific of scientific method within medicine from the perspective of ontological revolution and Cartesian dualism, especially in the context of mind-body or mind-brain problem? So how do we know what we know? We could summarize this question in this way, okay? Ontological revolution, namely the inner and outer criticism toward what is essential and what is valid. If you remember our discussion of medical terminology, ontological has to do with the study of being, right? So onto plus logical, right? And dualism in our context, the dualism between mind and body or mind and brain, okay? Second question, is a disease or illness a mere list of clinical signs and or related biomarkers? Now, of course, we interpret in the medical field a disease or illness as a problem to be solved, a problem to be resolved, a problem to be fixed, something broken that needs to be addressed in order to fix, right? But there, in a broader sense, especially within traditional medicines, okay, a disease is also a signal, as in an oversimplified and pop philosophy way to describe this would be everything happens for a reason, right? Including a disease, including a medical problem. But this is a little more profound than that. What it means is that it is also a signal, the same way as physical pain is a signal to our body that there's a problem that needs our attention, okay? In order not to have this problem become chronic, okay? Third question, are clinical data, albeit valid in terms of quantity and quality, sufficient to describe a disease and provide correct diagnosis? Okay, should we rely on clinical data? In parentheses here, I wrote, although here we should not forget the parameters of necessary or required. Okay, so for each problem, we should keep in mind, is this presentation, is this trait, is this portion of diagnosis, is this observation sufficient, necessary, and or required to infer that this is indeed the problem, okay? In this context, I could refer you to Bradford Hill, the Bradford Hill criteria especially, to navigate these complexities. Is contemporary medicine a combination of evidence-based medicine and theoretical medicine? Okay? Is observation enough without a solid theory? Does the hierarchy of evidence need re-examination in its order, content, and concepts? This is quite important because the hierarchy of evidence has to do with priorities and judgment. This also means that we have to be careful in avoiding our own personal projection onto the needs of our patient. This can be a slippery slope because it had to do with bioethics, medical ethics, etc., and the concept of phronesis. If you remember what we talked about Aristotle, right? We talked about the three types of knowledge, right? So phronesis as this prudence, this medical ethics on one side, and then techne, the techniques, the technology, the skills that we utilize to achieve that goal of knowledge, and then of course episteme as in epistemology, right? The pure science, theoretical science. So what do we mean by trying to avoid our bias, our projection? We mean understanding where their patients comes from. For instance, in the context of oncology and palliative care, what do we mean as a life worth living? Now, I would like to skip for now more profound philosophical conversation on life, meaning, and purpose, but I want to at least bring to your attention that the heart of evidence means one thing in the field of science itself. Okay, so evidence means what can be proved. Okay, the connected to the concept of the principle of falsifiability, whether something is true or is not true, false or true, right? And that can be proved, and this is connected to biostats and p-values, etc., student t-test, Wilcox-Song rank test, etc., right? Study design, and so on and so forth. But also, what is enough evidence? Okay, what is there to prove and show us, right? Next question: are randomized controlled trial necessary and sufficient to validate a therapeutic intervention? Okay. Now, we would love to say that for everything, the golden standard, platinum standard will be meta-analysis in itself based on triple-blind, double-blind, randomized clinical control trials, right? But of course, there are situations where we don't have the opportunity or the ability, because of the complexity of the study design and the population study, to achieve that. So what can we do aside from RCTs in this specific narrow context? To what extent the positivistic aspect of the lack of hypothesizing and mechanisms are still part of medical science and practice? Okay, so how to navigate scientism, as this term utilized to define a believing science that uses science in a very narrow form of description. Description predicts upon the definition of science during the Age of Enlightenment and the Age of the Industrial Revolution. And the fact that we focus on observable data as almost a substitute for the opportunity to discuss things further and understand the difference between mechanism and process, okay? How does that inform medical science and practice? Then how do we define things in ontological and epistemological terms, again, focusing on essence as well as science, science is knowledge, which we do not pursue with the commonly accepted array of scientific methods and technologies? What things should we include and what things should we discard in our treatment, okay? Is medicine a form of natural philosophy, a hard science, or craft, technology, and art? Now, again, those questions are not simply to entertain, I don't know, a contemplative sense of let's wonder what the social construction has to do with the way we perceive science. Now, this is important in itself, of course, and it's connected to what we said earlier about white coat syndrome, white coat anxiety, placebo, and the ritualistic component of it. But we should also understand that there are ways to approach that outside of the commonly understood framework. Now, natural philosophy, it's not yet another term I would like to add here. There's plenty of terms that are complex enough, but natural philosophy is to some extent a substitute of natural sciences, okay, empirical natural sciences. And the term natural philosophy is utilized much more in Europe, especially in Germany, for instance, German-speaking world, rather than in the Anglo-Saxon world, right? So, and you can find a similar equivalent with natural history, or related terms in the Slavic or the Russian world, the former Soviet Union world. But we really identify the highest level of natural sciences. Okay? Is it possible to integrate the above form and definition of medicine also in relation to the steadily growing aspect of medical and scientific technology? Example, brain-computer interface, artificial intelligence, etc., etc. What is the room for each of these aspects in medical curriculum, education, and academia? So how flexible should we be in changing the medical curricula, I would say plural, because we might have different areas of investigation, whether a person is achieving an MD as opposed to a DO, for instance, okay? And what type of research is considered to be the priority, okay? When we focus more on technology, more on epistemology, etc., etc. My wish is that those things should progress at the same pace, okay? So that we don't have too much technology for our own understanding, so we develop epistemological understanding at the same rate, or the opposite, we have a lot of theory but no practical application, and therefore it's just sheer abstract speculation with no effect on the well-being of our patient. Those things should be connected, but of course this in turn has to do with our hierarchy of evidence on one side and our hierarchy of needs from the Maslowian, for instance, perspective. Next question, why is it necessary to define forms of complementary, alternative, traditional, non-traditional, school and scientific medicine? Now, the classical question we mentioned multiple times is that why is there a need to talk about alternative medicine if it works and it's safe? It should just be called medicine. If it doesn't work, it's not safe, well, it's just reject it altogether. Okay? And for this question, I already referred you to related videos and lectures previously, so we should keep the conversation open about this specific area. And how do we define the above-mentioned forms of medicine? And should these be included in medicine therapeutic science? Okay, so is the question, do they work, why they work, and how often and how safely do they work, also from an epidemiological standpoint? More questions before we conclude this lecture. How do we define placebos, their biological effects, and their clinical and medical efficacy? Okay? So again, the separation between what is observable and what is perceived, and nevertheless as effective. Are there universal biomedical truth, or do we have to include and/or control for individual, culture, ethnicity, society, personal beliefs, spirituality, and religion in addressing this question? Okay? Now, of course, you might wonder, well, medical school, nursing school is complicated and difficult enough. Why should we include all these things? Well, we are already including them given the parameters, values, and system of beliefs upon which the curricula are based. So it's important to be aware of them. To what extent is modern academic, pharmacological, and biomedical research affected or even controlled by commercial interests? Again, I mentioned this before. I want to take a balance, in my view at least, balanced perspective between blind belief in everything sociological and mass media delivered, okay, and the opposite conspiratorial emphasis. For instance, is big pharma controlling all of us or not? Where is the place for that type of analysis? Okay, try to be as mindful as possible, at least, right? Do philosophical debate and position contribute to the advance of medicine as a science as therapeutic practice? This is a very important question because, again, we're talking about medical philosophy as focused on the how, right? And so there are areas where philosophy actually does change the way we practice healthcare, the way we practice medicine. Furthermore, is it necessary to exclude specific philosophy and or philosophical method from the paradigm of medical philosophy? This is also important because some of the criticism might have stemmed from the very contemporary postmodernist approach to science in general, an approach that very often, not in all cases, but very often is associated with criticism for criticism itself, as if that we cannot rely on any scientific data. And I personally reject this extreme view, extreme in my mind and the mind of many other scientists, because it contributes to the lack of trust in science. And this is very concerning, especially from the perspective of medicine. We should rely on science. We should qualify, quantify, and further investigate the validity of the method utilized in science. But there is a part of our own predisposition and intent and attitude toward believing in science that, in my view, should be defended. And this concludes our discussion of week 11, this slideshow, this video lecture. We analyzed medical philosophy and medical criminology, these two main areas. And I hope that you enjoyed the theoretical discussion and the practical application of all these elements. I will see you all next week, which is week 12. As usual, if you have any question, feel free to email me. Thank you very much, and I will see you all next time.